We're happy you've decided to join us today for Are You Prepared? The Next Generation of Orthopedic Service Lines. A few housekeeping details before we get started. This webinar is being recorded, and you should receive a link to the recording and the slides tomorrow by email. Please feel free to share this webinar with colleagues who could not attend today. A question and answer session will immediately follow the presentation. If you have a question for our speaker, please type it into the questions box in the GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by Wellbe. Wellbe's Episode Performance Management delivers the tools you need to tackle the new world of accountable care. From pre-procedure preparation to inpatient care to home recovery, Wellbe's solution includes guided experiences for patient engagement, care coordination tools for team efficiency, and real-time analytics for episodic intelligence. To request an executive briefing on how it could help transform your service line for the future, please visit us on the web at wellbe.me. I'd like to introduce our speaker for today. Cecily Lohmar is a founding principal with New Heights Group. With over 25 years in the industry, Ms. Lohmar brings to client engagement specialized expertise in strategic planning, service line planning and development, integration consolidation strategies, and physician strategies, as well as facilitating organizational retreats and planning sessions. She's a frequent speaker on organizational service line development and business planning for key service lines like orthopedics and neurosciences. Cecily, I'm going to give you the controls and you can take it away.
Thank you, Megan. I think I've got it. Thank you, Megan. It's good to be here, and I hope this will be of use or value to all of you. We're going to talk about what I call the next generation of service lines. There has been, over the last 10 to 15 years, a tremendous growth in service line development, and really it started with the idea of focusing on our most profitable services. And orthopedics was often one of those. Certainly neurosciences was another one. And the idea behind the service line initiatives initially was to grow, increase profitability, and therefore for the overall organization. One organization, for example, I worked with, 35% of their surgical volume was orthopedics. So clearly that was a key service for them, and they created it into a service line where they could do even better. So that was the whole idea behind it to begin with. But as we all know, things are changing. Watch the news any night and we get an idea of some of these changes coming forward. Whether it's accountable care, whether it's bundled payment, or whether it's just our insurance companies looking at us very differently and our consumers looking at us very differently. We have to change, and I'm a big believer that service lines need to change. We need to evolve if indeed we're going to continue to provide value to our organizations. And that's what this is all about. It's not about what we have been doing. It's about what we need to really be looking at as service line leaders or service line managers, and creating an environment where we continue to be of significant value to our organizations. I'm going to touch on 5 different areas that I think we need to consider as we evolve. One is the whole concept of how we're defining service lines, and I'll talk about that in a minute. That is a discussion that needs to be had at the leadership level in your organizations, but it's a pivotal one, and as you'll see in a minute, we're getting more and more and more service lines within our organizations, and it's muddying the waters. So we need to really clarify the definitions of what is and is not a service line. We also really need to look at the continuum, and I would imagine that many of you have already started looking at broadening your continuum of care. Certainly the bundled payments, depending on which one we pursue, they're looking at that as well, looking at a bundled payment that includes some level of post-acute care. But as we expand our continuum, we also need to really focus on integrating it. And a continuum in and of itself is of no real value unless we integrate it. So that's the other key piece to evolving this service line. Along with that is the whole concept of how we're defining value and how we're measuring our performance. And as you'll see, as we'll talk about, that needs to shift as well. As the market changes, as the way we're getting paid changes, as the consumer involvement changes, so does the way we define value and the way we measure our performance. And then the final two areas that need to evolve are ones we're hearing a lot about. The first is physician alignment. That's the $64 billion question for everybody, is how do physicians and hospital providers align more closely? And specific to this, how can we get physicians more aligned with our orthopedic service lines? And that dovetails with the leadership structure. That's something I speak about a lot, just the leadership structure. I actually do a 2-day seminar, I had been doing a 2-day seminar, my partner's taken it over, but on just the organizational structure for service lines. And that is something that I hope you will go take away from this presentation and really evaluate for your own organization whether or not you have the right organizational structure to do what you need to do in your orthopedic service line. So that said, let's take it from the top and start with the definitions. When the concept of service lines first became popular, it was during the 90s. There was an initial wave in the 90s that kind of softened a little bit, and then after 2000 they started up again. And they became, as I mentioned, they were the real profit centers for us. It was cardiac, it was ortho, it was neuro, it was oncology, in some cases it was women's. The ones that pretty much everybody has these days. But what we've been seeing over the past several years is a lot of other, quote, and I'm going to use in quotes, service lines coming on board. And this shows something from the advisory board looking at wellness and preventive services as a service line. Primary care, I hear people refer to as a service line a lot, as well as geriatrics as a separate service line. But if you look at these, you have to ask yourself what you see up there. Where does that 70-year-old with congestive heart failure fit? Or where does that 85-year-old joint replacement fit? Is that orthopedics? Is that they've got primary care? Is that geriatrics? If we do some wellness initiatives, should that be done strictly by the service line, the wellness service line, or does that fall under orthopedics? If we're doing athletic screenings under our orthopedic service line, is that something that's really part of wellness? So it's ripe for confusion, and this is where things are getting muddied out in the marketplace. People are looking at service lines differently and defining them differently. So it's kind of becoming what I would call a garbage can term, and it shouldn't be. It should be connotated as something that is very strong within your organization and as a very important entity within your organization. But if you see the yellow boxes here, people are defining service lines by settings, primary care, ambulatory care. Behavioral health is kind of a setting. It can also be a diagnosis. But post-acute care, those are settings. They're places where we receive care, as opposed to the diagnostic-based service line, orthopedics, cardiovascular, oncology. That's how we started. It is a group of diagnoses or disabilities that fall together. But then we're also seeing people define service lines through demographics, a women's service line, pediatric service line. But as you can see, each of these bubbles touches on others. You may have a female runner who hurts her knee. Does she go into orthopedics, or is she being seen by the women's service line, or does she get cared for under primary care? So there's a lot of areas of ambiguity, and I'm not suggesting one or the other. I do personally think it's clear if it's diagnostic-based. But even if it's not, it needs to be very clear within your organization of how you are defining a service line, who's in, who's not in, and how you're going to relate with all these other service lines that your organization might be bringing on board. Once you've got that down, you need to start investing in the continuum, and I would probably imagine most of you have already started pursuing this, whether it's just going after outpatient PT providers, whether it's going after skilled nursing or rehab, inpatient rehab, doesn't matter. But I hope you have already started to look at this. If not, it is time you do. Really look at investing in the continuum, because if we're going to be accountable, even if it's just now for that inpatient episode, we ought to be realizing that that just means down the road we're going to be accountable for the entire thing, from injury, in terms of orthopedics, from injury all the way through getting back to full capacity or even limited capacity if that's the best they can do. But we're going to be more accountable. That bundled payment concept, it seems to be getting steam, and we'll need a continuum to make it work under that. There's a decision that needs to occur in this process as we develop our continuum, and it's the make by partner decision. If we need to get outpatient satellite PT clinics, for example, we need to decide if it's better for us to actually make them, to do our own, take our brand and go out and create our own clinics, or if there's a clinic out there we might want to buy, or if there are clinics out there we might want to partner with. And that's a pivotal decision. And this checklist we put together a number of years ago for when the first integration or consolidation initiatives were occurring. And it's still relevant today. So if you've got the idea of bringing in skilled nursing, bringing in acute rehab, bringing in outpatient rehab, whatever it may be, go through this checklist and just circle the answers to the questions, and it'll give you an idea of what your strategy, what the best strategy may be. For example, if we continue with the PT example, an outpatient PT, some satellite clinics, do we make it, do we buy it, do we partner with it? Ask ourselves first, do we have the expertise to do this internally, in-house? Do we know how to run satellite physical therapy practices? And having an inpatient hospital-based PT practice doesn't count. Do we have somebody who knows how to run the outpatient side of the business? Do we have facilities available? If we know how to run the business and we've got available facilities, then that might be something we can create. But if we don't, then we start looking at buying or partnering with that for that service. Same thing is there a market leader? If there is a leader out there in the marketplace, I worked with an organization a while ago that was going through this, and as it turns out, there was an outpatient PT provider who had a stellar reputation in the community. Everybody loved him, physicians and patients alike. He was well known in the sports medicine community. He was a market leader, and if you've got somebody like that, you really have to ask yourself, why do we want to try to create something to compete against it? That really does lend itself more towards buying that service, i.e. acquiring their practice, or partnering with that person to become part of our continuum. Other questions include, what is the demand in the marketplace? If it is a really high unmet demand, then that does favor our making it ourselves. What are the barriers to entry? Is it a reimbursement issue? Is it a transportation issue? Are there other barriers to entry that may come into play? And if there aren't, again, maybe easier for us to just put an outpatient PT practice up there on our own. But if there are, we look to buy or partner for that service. Cost to provide and the organizational culture are the final two. I'm going to talk a little about the organizational culture because that's really a pivotal one. If we are trying to get access to a service that has a very different culture from the hospital, then that does not bode well for our trying to make it. And there's plenty of examples in the hospital industry of times when we have gone after a new service and it has failed because of cultural reasons. SNF may be an example. If you use skilled nursing facilities, that is a completely different culture than acute hospital care is, or even outpatient care. And so for us to just look at it and say, well, a nurse is a nurse is a nurse, is really going to shoot ourselves in the foot. We need to address that and say, actually, long-term care or skilled nursing care is a very different business, a very different culture, different reimbursement mechanisms, different staffing assumptions, different everything. And it's not so easy for us to just think we can go in and create it. We may be better off either acquiring that service or coming up with a formal partnership to create it. So investing in the continuum is really a little more complicated than many of us think about. If for us to do it right, we really need to go through these kinds of questions and ask ourselves what makes the most sense. Easy way to use this kind of a checklist is just circle the answer that makes most sense for your organization in your situation. And when you get down to the bottom, add them up. And this is really high tech. And add them up, and whichever has the most circles is the strategy that probably makes most sense for you, at least the way for you to start. The other piece that is not really big in orthopedics, although it really could be, I believe, and that is the chronic care situation, that we really need to take a proactive approach to chronic care. And there are three basic strategies that people are pursuing with this. These are the folks who are the high users. They're very expensive to hospital organizations because they use the ED a lot. They use inpatient services a lot. They're just the very high users and very costly to any organization. And I think there are probably a number of our orthopedic patients that could fall into this. And if that's the case, we need to address it within our own service line. So people can do a number of things. What I think makes most sense is to integrate chronic care into our service line as best we can. And so if you've got an orthopedic service line and some of your chronic patients are patients with joint disease, whether it's rheumatoid arthritis or whether it's osteo or it's joint replacements or whatever, if that's your chronic care population, then you as a service line leader need to address how you're going to care for that population. Most of your service lines, you're probably really oriented around that acute injury or disability. But we need to take a step back and say, if we're the experts in dealing with any orthopedic injury, then that should apply to chronic care as well. not going to spend too much time on this, although if you've got questions, please feel free to ask and we can address them at the end. Because, again, I think most of the chronic care patients that we see in service lines touch on orthopedics. I don't know how many would start in orthopedics, but you folks know much more about that than I do. The other piece with the continuum is to integrate it. I mentioned it at the beginning that we can have a continuum of care, but the value is really minimal if we do not integrate it successfully. In other words, the goal of the continuum is to provide a seamless service, a seamless continuum of care for the patient, not for the paper that we fill out, but rather for the patient. They shouldn't feel a big difference when they move from setting to setting. They should see consistency in how we're providing care. They should see consistency in the way they are treated, etc. That said, there are different ways to integrate. And we want to make sure if we've got multiple members of our continuum, we want to make sure that the way we integrate doesn't dilute the specific value that they are providing to us. And again, an example, if I go back to the sports medicine practice that we worked with, they wanted to acquire the practice, but their idea was to bring the practice in and basically absorb the practice into the hospital. And what that would have done is taken away the real value this practice was providing, which was very close relationships with physicians, one-on-one relationships with clients. We'll stay as long as you want us to stay. If we need to stay late, that's okay, as opposed to, no, we close at 6 tonight. Just a very different orientation, a very different culture. So that would have really diluted and or made the acquisition meaningless and worthless to the organization if they had just tried to absorb them into the hospital. What they did instead is they ended up keeping them very separate, kind of an arm's distance apart. But he became part of the management team so they could make sure that they were doing things consistently across the board. So this little checklist is an effort to, again, start asking the right questions about how we want to come together. There are 3 ways of integrating. Coordinating is strictly a very informal way of talking with each other and saying we're going to do things consistently. Integrating is more what the example I just gave of the sports PT owner, where he became part of the team and they really did things together. Consolidate is what I said they initially talked about doing, which would just absorb them into this large organization. That works sometimes, it does not work other times, and you need to be really strategic about how you're going to do it, which one makes most sense, because it may be different for your SNF than it is for outpatient, than it is for an acute rehab service or anything else. So some questions that you want to look at as you ask yourself, what's the best way for these settings to come together? Are the markets that each of you serves, are they similar, are they diverse? What's the distance between them? Gets back to, is there one entity that has a very strong image? Is your market really looking for service consistency? I mean, you're all in very different markets, and if you're in a very competitive, very sophisticated, as I would call it, market where the payers and the patients both are looking for some level of a consistency, they're looking for Starbucks or McDonald's, where they walk into any organization that has your name on it, they know what they're going to get. If that's where you're going, or if that's what your market is starting to look at, then you may need to look at consolidating the service. But if not, and many of our markets are not, then you don't need to do that, because consolidation has its own issues. It's often very threatening to people. But look at some of these other areas about financial. What are the payers looking for? And what's the culture in each of these areas? Once again, that culture comes back, and it'll always come back because it does tend to take over if we don't address it up front. So that gets to the whole continuum piece. Both the definition of the service lines and the continuum of care, 2 areas where we really need to pay a lot of attention in the next couple of years. We also need to look at what I call the value equation. What is it that we are offering to the customer? And the customer in this case can be the patient as well as the payer, and in some cases, especially in orthopedics, the physicians, although I think it's really shifting to more the patient and payer. Historically, we look at cost and we look at quality, but we look at cost. How many of us, just ask yourselves or answer this to yourselves, how many of you look at cost as in what does it cost the hospital to provide this service? Probably a lot of you are thinking, yeah, that's kind of how we look at cost. And look at quality in terms of CMS, core measures, the standard quality measures. I think we really need to start shifting that. And it is slowly shifting. But you need to go back and look at yourself and say, what is the value that the customer gets out of this? I've got a quote on this slide by Peter Drucker, and it's actually a pretty dated one. It's probably 15 years old, but it's still very relevant because we're not really looking at it this way yet. What is the value that you are bringing to the patient? I think in orthopedics this is particularly important because so much of what we rely on is elective, and we're all trying to get that elective population. So we need to really ask ourselves, what is the value we are providing to that customer? Why are they coming here versus somewhere else when they have a choice? And we may not want to look at things. Cost is still important, but look at things like copays. What do our patients, what are their copays for our service, and is that unwieldy? Just finished a project for a client in imaging. We were looking at a freestanding imaging center, and the reason most of the market went to the other guys, a freestanding center, is because of the copays. The copays were really high at the hospital, and they were very low at the other place where they could waive a lot of that. So that's part of the value to me and to each of you if you're going into for any procedure. What is it I'm going to have to pay out of pocket? What kind of fee scales do we have? Is there any latitude in how we charge patients for these services? And then some kind of a warranty. This is something that I find extremely intriguing. If any of you are familiar with Geisinger and have read what they're doing, it's called their Proven Care program. And right now they're orienting it around cardiac, but I think you could really do this around certain orthopedic procedures. What it says is that for people who qualify, and you have to meet certain criteria to qualify, if we don't get you to a certain level within a certain period of time, you're in essence getting your money back. So they're putting their money where their mouth is. And again, I think of that from the perspective of total joints. What if you could go to your market and say, if we don't get you pain-free and walking within X amount of time, we'll refund your money or part of your money or whatever. You're basically telling them we have enough faith in what we do and that we are doing it better than anybody else that we're willing to put our money on it. I think that could be very powerful, and that is of value to people. And then the quality equation, the same thing. I know most of us measure pain, mostly because of the core measures and HCAHPS, and we're measuring how much kind of patient satisfaction or caring. I think that we really need to start looking very strongly, if we haven't already, at how we're measuring return to function. And by function, I don't mean that range of motion is now 90 degrees when last week it was only 60. That's not return to function. I'm talking about, can I play tennis again? Can I play golf? Can I walk the dog? Whatever the patient sees as a return to function, that's what we need to start measuring. And people in orthopedics have been going round and round and round and doing this for years. Rehab does this rather well, and we could take some lessons from the rehabilitation industry in looking at function. The FIM scores, if any of you are familiar with rehab, have been around for quite some time, since I was a clinician, which was 20 plus years ago. We're looking at FIM scores, and those are independence, functional independence measures. Suggest you look at some of those if you aren't familiar with them and see if any of that kind of measurement might apply. You may not have national benchmarks until we get those, but at least you could start talking about the quality from the patient's perspective, and that is, how can I return to function? So with that, we need to rethink what we're measuring. Historically, service lines have been measured as a % of procedures or a % of admissions or a % of surgeries. It's market share. But as we look more towards population health, towards these comprehensive service lines, full continuum, I think we need to ask ourselves, what % of that service line population are we capturing within our system? Very difficult thing to measure. Most of us don't have the IT structure to do it, but I think with the changes we're seeing in IT, I think that's down the road. So what % of, if we've defined orthopedics as people with these disease states or disabilities, what % of that population are we capturing in our primary care offices, in our physical therapy clinics, in our surgical suites, et cetera? That, to me, is a much more valuable number going forward. Same with the old process metrics, performance metric. What did I do? I did, X, Y, Z. I gave them an antibiotic. I gave them an anticoagulant, et cetera, et cetera. I did those things. Versus the new performance metric and the new report cards you should be filling out was, Did it work? Is the patient doing better? They're walking, okay, that's great, but 3 months later, are they back on the court? Are they back on the golf course? How did it work? What was the real outcome from the patient's perspective? And then the old measure that we've always used is the profitability. As I mentioned at the very beginning, that was one of the reasons that service lines took off in the 1990s and early 2000s, is looking at profitability. I think in the future, again, with population health, we'll be looking more at cost per population, cost per person in the population, almost like a capitated cost. Talk a little bit about physician alignment. This is the, as I mentioned, $64 billion question. What we're going to see down the road, this slide here just looks at all the different alignment initiatives that people have undertaken, whether it's advisory councils, co-management, joint ventures, IT networking, et cetera. It's across the board, and you can see here as you go to the right, the scope of activities increases. In other words, it's covering more and more things. And as you go up higher, it's the degree of integration. In other words, just how tight is that alignment. So an advisory council doesn't do too terribly much, and it's not too integrated. It's just a very soft, loose structure. Whereas if you go way over to joint contracting, co-management, full integration, that's covering a lot more services, and it has a lot more integration. There's a lot more alignment teeth, if you will, they're making happen. So there's going to be much more that those initiatives can do, but they're obviously not as easy to do. I could spend probably a couple of hours talking just about some of these alignment initiatives, but what I think I'd like to leave you with is just to take a look at this, become familiar with these if you're not already, kind of the pros and cons of each, and ask yourself where you are today and where you need to go from a service line perspective. Right now, I will, kind of a warning, if you will, a lot of organizations are jumping on the co-management bandwagon. It's very popular right now, just like PHOs were in the 90s. I'm not necessarily sure that's the way we want to go. So I would just caution you to be very sure you know what you're doing when you're going down that road, that you don't just do a knee-jerk reaction to get a co-management agreement. They can be extremely valuable and extremely successful, but they're not necessarily the right strategy for everybody. Question I have for you, and I think we're going to take a poll here. I'd like you to answer the question of how many medical directors do you have for your service line, for your orthopedic service line? Do you have one? Do you have, I think, 2 to 4 is the other option, or more than 4? And then we'll talk a little bit about this.
Okay, the poll is up on the screen, so just select one of the radio buttons and let us know how many medical directors you're using in your ortho service line currently. Like we've got 50% of the audience in already, so get your vote. I'm going to close it in just a few more seconds. So last minute. Okay, and I'm going to share the results with everybody. It looks like we have 53% of the audience has 1 medical director, 45% have 2 to 4, and 3% have more than 4. Okay, good. There's not a right or wrong answer. I should have said that at the beginning. There's no right or wrong answer. But I do think as we're looking at alignment, we really need to rethink how we're creating and what we're doing with our medical directors, because there are opportunities there that perhaps we are not taking advantage of. And for those of you who have 1 medical director, I would really emphasize this point, that you can probably capture the interest and the energies of a number of other physicians if you can branch out. And the concept of this multiple medical directors is just that our service lines are becoming so complex, and the market is becoming so complex, that one person probably can't do all of it as effectively as perhaps more. It's like 3 heads are better than 1. So people are organizing service lines around different medical areas and getting medical directors for each. So you might have 1 overall medical director, but you also might have a medical director by specialty. For example, you could do an orthopedic medicine and an orthopedic surgery medical director, depending on what you're capturing and what you want to do. You could do it by disease and or by the program. You could say we're going to have a medical director for total joints, a medical director for sports, a medical director for inpatient, and a medical director for outpatient. Again, breaking it up so that you're getting more and more physicians engaged in what you're doing. You
can do it by population. Within orthopedics, we've got a geriatric medical director. So that's the person that really oversees what we're doing for everybody over the age of 65, 75, whatever you want to call it. And that allows you to focus on that population a little differently. Do we do more fall prevention? What is our trauma system like, even for people who just break their hips and have to come into the ED? That is trauma. How are we managing that? You can also do it by function. This is a real common one where you have a medical director over quality, one over technology, one over perhaps continuum development. I think I really encourage, and I am a big proponent of the multiple medical directors model. You may need to have that one who's ultimately at the top, and we'll get to that in just a second. But this really does allow everybody not just to be heard, but to have an active voice in your service line. They may not have a lot of authority, but you can give them a fair amount of clout. I mean, and you kind of weigh that as you go. But you can say, if you're in charge of sports medicine, we want you to create that. You're in charge of creating that team, bringing it together, getting some consistency in care, et cetera, and let them run with it. And I think what people are finding is this is what physicians do well. They want to take something and run with it. So you're, in essence, instead of giving them a patient and letting them go with it, your patient is the total joint program, and now run with it. So I would heartily encourage you to take a look at this, to think very seriously about how you might expand your medical director roles and functions and that whole structure under the medical director.
Actually, we did have one comment from someone who said they have 0 medical directors.
There you go. Then I think that person needs to get one. I mean, I don't say that in jest. I think we have to have our physicians involved in what we're doing. So if we do not have a medical director over orthopedics, first thing would be to try to take a look at how big your service line is, what's the predominant, or what are the predominant areas that you focus in. Is it total joint? Is it sports? Is it just general, a little bit of everything? What populations are you serving? And see if you can bring it, survey your own physicians, do your own survey of your physicians, and see if there's somebody who you can engage to move your program forward. I would argue you're going to have a hard time really taking it into the future if you do not have active and engaged medical staff. And this is kind of the easiest and most obvious way of doing it. And we'll get into the whole org structure in just a second, because the physician will come back with that one. You do need to be, with medical directors, you need to be very clear and have job descriptions for each of these. In many cases these days it's a paid position, but it doesn't have to be a huge amount depending on your service line size. And all of this is really dependent on what size your service line is. But I think you need to look to your medical directors for program development, for recommendations regarding technology, recommendations regarding market development, recommendations regarding recruitment, et cetera. There's really a lot of work that they can do, and you put it down on a job description rather than just a soft do what you want to do type, the old way of having medical directors. This has to be a very structured and formal engagement. So we'll talk more about or not necessarily just the person that does not have a medical director, but we'll talk more about the physician in a minute, because it really does come down to how are we going to position our service lines for rapid change. Everybody knows Amazon, everybody knows Toyota, everybody knows Google. They are all structured, and there are many others, but these 3 organizations have an organizational structure that gives their product line managers a pretty tremendous amount of control over operations, new product development, acquisition of new technologies, full quote-unquote continuum. In this case, it's the whole research development all the way through sales, and pricing. And that structure is what allows them to, in Toyota's case, be the first one to get the hybrid car on the market. I'm less familiar with Amazon and Google, but they are known as being quick and restructuring quickly. Amazon's starting to talk about using drones to drop your products, if you will, rather than just the mail. I mean, that's innovative. That's part of that culture is driven by their structure, which is product line managers that have a fair amount of control. Now, this is a lot more than I think we'll ever see in healthcare, but it's something that I want people to start thinking about and heading towards. And what that means within healthcare is that we've got to get that product line, or in our case our service line, structured in a way that we can respond quickly, because the market is changing quickly. And we need to be able to move. If we're going to continue to create value, we need to be able to change quickly. The first thing that I would suggest, if we do not already have it, is that you create a team, if you will, to manage your service line. I probably should have asked this one as a poll question as well. But if it's just the service line manager and that's it, overseeing your service line, you're missing a tremendous opportunity. The most effective service lines that I see are those that have what I call a dyad structure. They are managed by an administrative person and a physician. In many instances, they have 3 people managing it, a nurse, administrator, and physician. But I would say by and large, for most organizations, 2 is what you're going to be going with. And so again, if you do not have that in your structure, strongly suggest you get that down, where you are working hand in hand with a physician, that's your medical director, with a physician to bring that service line forward. Now in this case, when I talk about that physician, the medical director, I'm talking about the overline medical director who's overseeing the entire service line, just like you are. So again, first thing in terms of getting the structuring for change is to make sure we have that dyad structure in place. The next one, and this is an area where I really see a lot of organizations challenged. I will tell you the most common challenge I see, issue I see, is I will get called by an organization, our service lines are not performing as we anticipated, can you come take a look, et cetera, et cetera. And what I will find is that the service line manager is giving a ton of responsibility for improving performance, improving quality, growth, et cetera, but no authority to do so. And that's setting you all, I may be talking to many of you with this, that's setting you up for failure, or at least setting you up to not do as much as you'd like to do, and the organization as well. So we need to really make sure that we have matched the strategic goals, what we want to do in that service line, with the autonomy and the authority that that service line manager, that service line dyad, the physician as well, have. So that we're not asking the service line team, the manager and the physician, to do something, we're not holding them responsible for something that they have absolutely no authority over. And the most obvious example, quite frankly, is to say you're responsible for profitability in the service line, but you have no control at all over the nursing units, the surgical suite, and rehab. Just even inpatient, if we just want to stay inpatient, just that. If you start looking at outpatient, it gets even more complex. But if you have no authority at all over those areas, you can't really be held responsible for managing the cost and the financials. So I'm not saying you all need to move where you all oversee the nursing unit, surgery suite, et cetera, but you need to have some more formal relationship with them, or you need to change some of the goals. So this is probably just, these are questions that you need to take to your own internal leadership. But say, are you asking me to do something that you're giving me no authority to do? And I think that's going to become more and more evident as the market continues to shift and there's more pressure placed on the service line leaders. This is a continuum that we've put together for a class that we teach on service lines. And it's looking at 4 different models, organizational structure models. And these are our terms. Service line promotion, leadership, execution, and organization. And if you look at the x-axes, the further you go to the right, the greater the ability to add value. So the models to the right, service line, execution, organization, have the potential to add most value. On the left, on the y-axis, is how difficult they are to do. So again, the ones that have the potential to create the most value are the most difficult to do. And right now, I would say 90% of us are either in service line leadership or service line execution. This is a slide that gives you an idea of where you might be and what might be where you need to go. But let me talk about the difference between those two. The service line leader is the one who is given the responsibility of usually program development, market development, physician relationships, growth, quality, et cetera, but they have very limited, if any, operational oversight. So nobody really reports to them, or perhaps just a couple people. But as I said before, nursing units report to nursing, the surgical suite reports to surgery, et cetera, et cetera. And that's the service line leader structure. The service line executive is somebody who does have that authority, and either all or part of the operations of that service line fall under the executive. It's kind of like that mini COO. And if you use this matrix that we've got here that has the promoter, leader, executive, organization at the top, and look through, once again, each of the boxes and shade in or circle what is most reflective of your own organization, it can tell you where you are today, but it may also give you an indication of where you need to go. It can highlight kind of the inconsistencies with where you are today and what they're asking of you. So I think it's really important that we understand, just like we have to clarify our service line definitions, we need to clarify our service line leadership structure. What is it we're asking them to do, and making sure that the structure, the organizational structure itself, is set up in a way that allows them to do that. And I'll tell you, yeah.
You poll, this other poll you had?
That's right. Yes, we did have another poll. I'm sorry about that. Just where you are today, what you would say, where you would say your service line lives right now.
So we've launched it, and we're asking, do you have responsibility and authority for service line performance, or do you have maybe just responsibility and no authority to do something? So 23% of you are in. Get your votes on by just clicking the radio button next to the response that represents you. And then we'll share the results after a couple more seconds. All right, last chance to get your votes in. All right. We have only 13% of our audience has full responsibility and authority. 50% have limited authority, and 38% have responsibility only.
And thank you. That's probably pretty reflective of where we are as an industry. And I think where we need to be looking is more towards the responsibility and authority. And even the limited authority probably needs to be expanded if we are really going to be able to maneuver in tomorrow's environment. And this all gets back to the service lines continuing to add value, because I think you're going to see your CEOs, COOs start to question, why do we have a service line structure here, as they're being pushed into other areas because of the market changes. So I think we need to recognize, or we need to be able to go to them and say, here's why we have value, or how we might have value in the future marketplace. But to do that, here's how we need to be structured. And I do believe if we're going to be held responsible for bundled payments, for any kind of value-based purchasing, for any kind of value-based payments, you need to have some authority over what is done. And I'll be honest, the shakiest one for everybody is where your service line leader has responsibility for unit managers, or I'm sorry, units themselves, inpatient units, because of course that challenges the traditional nursing silo. It's very challenging. But in organizations that have done it, it's been, after a little while, it's like no big deal, because your CNO still remains responsible for overall professional development. You just have somebody else overseeing the day-to-day direction of that unit, so it's consistent with everything else in the service line. All of you who are service line managers need to really make sure that you have the skill sets that you need for tomorrow's environment, and if not, go out and find them, get them. Here's what I see for tomorrow, is that our service line managers need to really be responsible and be savvy in strategy development as well as operations. They need to be more of an entrepreneur and comfortable with managing change and helping others manage change. Financial management, which is often an area of weakness for many. I'm not talking budget management. I'm talking about saying, if we get this piece of equipment, this is how long it will take us to get our return on investment. They need to be somebody who can develop partnerships and negotiate those partnerships, and they need to be somebody who understands process reengineering. You don't need to be, a Six Sigma black belt. You don't need to have necessarily even an MBA, but you need to be a mini chief operating officer, If you look at your COO, or maybe for some of you, your CEO, the skill sets that they have are what you need to start looking towards for your service line manager. Those kinds of skill sets just on a smaller scale. But I believe that a lot of our service line managers are the future CEOs of tomorrow's hospital and health systems. Let's not forget our physician leaders, because we need to be partnering with them, and they need to be helping substantively. And again, this is a little bit of a change, I think, for many people. Historically, we've had the medical directors, but it's been kind of a very soft title. There's not been a lot of meat to it, and that's changing. The person that you are partnering with, or that you should be partnering with in managing your service line, needs to understand and know how to get physicians engaged, how to recruit and retain physicians, how to manage quality, because quality is going to fall under your physician, not so much under the administrative side. How to manage quality, and that means going up to other physicians and saying, we've got some problems, but managing other physicians' quality, probably an easier way to say it. Implementing and supporting evidence-based practices and managing utilization. Those are all skills or those are all responsibilities that fall under the medical director, or should be falling under the medical director. And they're going to gain more and more importance as we get more and more into some kind of accountable care, value-based markets, population health, et cetera. So we really need to start evolving our physicians as much as ourselves. So just to close, that's a lot of stuff to throw at you, but hopefully there was some helpful information in there. Some questions to go back and ask yourselves. Are your service line definitions still valid, or do you need to clarify those? What about your performance metrics? Have you integrated the continuum into your service line discussion? And if not, how can you integrate the concept of a continuum into your service line discussion? Have you tailored your alignment options? Have you looked at multiple medical directors? Do you have that dyad, that service line administrative side and physician? That's the dyad leadership. And do you have the needed authority to create change? Do you have the skill sets, and is your service line structure clear to everybody? I didn't talk too much about that, but that just means, do the people in finance know who reports to whom within your service line? Because there's a lot of matrix going on in all service lines. So is that structure clear to everybody, not just to you and your boss, so to speak? So at this point, I'll entertain questions, I guess. Megan, you can open it up, I think, for questions.
Great. Thanks, Leslie, for that informative presentation. We will now open it up for questions. If you have a question, please type it into the questions box in your GoToWebinar panel on the right side of your screen. While everybody's submitting questions, I wanted to remind everyone that today's webinar is sponsored by WellBe. WellBe's episode Performance Management delivers the tools you need to tackle the new world of accountable care, from pre-procedure preparation to inpatient care to home recovery. WellBe's solution includes guided experiences for patient engagement, care coordination tools for team efficiency, and real-time analytics for episodic intelligence. If you'd like to schedule an executive briefing on how it could help you transform your service line for the future, please respond to the poll that I'm going to put up on your screen. All right. Let's see our first question. Somebody is asking, where does patient experience staff fit in, and are clinical and support services eager to align with these service line leaders?
The patient experience factors into the value. And actually, in my view, it's becoming more and more important. I think the slide talked about caring, and that's the patient experience. Was it positive? Was it not? And for that matter, I think for many of us, we need to measure not just for the patient, but for their family and or caregiver. Just having gone through this with an elderly mom who broke her hip and such, it was fine for her, but I can tell you my experience, I would have filled that form out very differently. So that is a critical piece, but it does come under the value, how we're defining value. And again, I think if we've got just stellar reports on our patient experience, we need to let the world know that, especially in orthopedics, where so much of what we do is elective and people can choose where they go. that means we need to capture them. We need to give them a reason to come to us, and patient experience is a great one.
Great.
Good question.
What's your experience with orthopedic service lines in a hospital with several small orthopedic groups, one of which operates its own outpatient therapy clinic?
Oh, fun. The challenges are obvious. Probably everybody in listening could relate to this. The one I'm thinking of that I did work with, there's nothing you can do to say you can't have this therapy piece. So that's done, but you can still work with the group. And so I think that's very important. Even though they may be competing with you in some areas, if you can get them engaged and truly engaged and maybe become part of the process, if you will, you may find that they are less competitive. I'm not saying that they're going to close the practice that they have, but they are, when they start understanding your situation, I think a lot of physicians can be much more accommodating and really do try to help. Now with the 7 groups, in that case, I think you do need to get them together on a relatively regular basis. That may be where you need that advisory council that I mentioned. There's not a lot of teeth to an advisory council, but it's a mechanism for bringing them together. And maybe they select the medical directors for the different areas. That's something to really think about. They need to have, when you get them together, they need to have a common goal. And it can't necessarily be help the hospital. That doesn't go over real well. But it's more, how do we grow this service? That's the common goal. And so I think the challenge for the service line manager in there is when they come together to keep them focused on what's good for everybody, a win-win for everybody, as opposed to what we often do in hospitals is say this is going to help the hospital and may or may not help the physician.
Right. Kind of a related question here from Meg. She asked, what do you think orthopedic surgeons are looking for in terms of future business models or strategy?
You know, I think I heard at a conference not too long ago that even at the, what is it, AAOS, their group conferences, they're talking co-management, and because there's an opportunity for them. So I think there are a number of physicians who, in orthopedics in particular, who want to own a piece of our service line. And that may just be the personality of orthopedic surgeons. You know, as we all know, many of them are kind of they're the quarterback mentality. I'm in control of the show, and that's where I'm comfortable. So I think that is why we're seeing a number of orthopedic groups trying to get into some kind of a co-management arrangement. And that's not necessarily bad. So I'm not, but as I said before, let's not just jump into it just because everybody else is doing it. But it can be very effective. So that's where I see orthopedic surgeons going. A lot of them are, oddly enough, slowly going towards a stronger relationship with hospitals, some towards employment. But I think we're going to see orthopedists going towards greater alignment. They're going to be initiating more alignment with the hospital. I think co-management is what they're most comfortable with. But I believe in some markets where the elective surgery volume has gone so far down due to the economy, and now I think, I'm not sure it's ever going to go back up to where it was. I think those are the markets where physicians, orthopedists, who have never been amenable to strong relationships with the hospitals, are going to start wanting to partner up.
Great. So that's all we have for today. If you have questions that you didn't have a chance to ask, please email them to me at info@wellbe.me, and we'll get back to you. Or if you want to connect with Cecily, I can connect you with her. Everybody watch your email.
And Megan, can I just throw out there, if anybody wants to go to our website, we do have a number of white papers, and we just recently put one on there that covers what I just talked about here today. So there might be some useful information in some of those white papers. There's one on orthopedics and several on service lines.
Yeah, and that's, I can send that link out with these slides and recording, which everyone should have received tomorrow morning. So thanks, everyone, and have a great day.
Thank you, everybody. Thanks, Megan.